Welcome to Care Chat, where we pull back the curtain, lift the veil on, and just demystify senior care services, not only in the Chattanooga area, but kind of industry trends and where we see things going, just even on a national level. This episode's sponsor is Right at Home of Chattanooga, Cleveland, and Athens. Full disclosure, I am a part owner in that business, so it's pretty easy to find that sponsor in this case. But Right at Home keeps seniors and disabled adults safe and independent wherever they call home. So enough on that. Today, I'm going to play your host for Care Chat, and we're going to be speaking with a lot of colleagues, friends, new connections, people we've worked with in the past, people we hope to work more with in the future. And today, our first guest, Jeanie Christian. So Jeanie, we've actually just met in person for the first time today, although you've worked with the Right at Home team for the last couple of years, and we've met over Zoom and things before. But let's just start off by talking about what you do, and then we'll go backwards from there, probably.
Okay, sounds good. Sure. So I'm an aging life care manager, which is a geriatric care manager, which is a private social worker, for lack of a better term. So we help families when they have parents who are aging, declining in health. We also help the special needs, and we kind of just come in and help them run all the different pieces of their lives, whether they need care at home, if they need assisted living, if they need someone to show up at the hospital. So it's always easier when I tell stories about it. But but I've done social work for 30 years. I've worked with older adults for a long time, worked in nursing homes, memory care, placement, elder law, a lot of different things, and all those pieces are part of what care management is.
So you basically, after all that experience, you were like, I need one thing that involves all those things.
All of it.
And then you just kind of went for it. I like that. So how long ago did you start your business?
2 years ago.
2 years ago. The middle of mayhem.
Middle of mayhem.
What better time to start?
I'm telling you, people have needs whether you're in COVID at home or not.
Yeah, for sure. So that's, obviously you have a massive background with a ton of experience, but let's rewind even further. So what started your interest in working with seniors or disabled adults or special needs, that kind of thing?
Yeah. Well, my great-grandmother lived with us, and so I helped do her caregiving, and then my great-aunt lived with us. She had Alzheimer's. She ended up moving into a nursing home at the end, but helping care for both of them was just natural. My family went to St. Barnabas, and every Sunday, almost my whole life, and my dad played the organ, and so I was just always around older adults and always used to wheelchairs and good smells, bad smells, and so now I made my daughter do it recently with Girl Scouts. I had all the Girl Scouts come sing, and my daughter knows awesome. You go hug, you love on people, and the other girls are like, what? But to me, just being around older adults and loving on them is just kind of how I started. Yeah, that was my whole life.
My daughter is in her first year of Girl Scouts, and so that's another story or another thing, but she's loving it and all that. But that's interesting. So I didn't come from any kind of healthcare background before we started Right at Home. We, in fact, when I think back, a lot of my friends had either, adult or grandparents that were still aging when they were like they still have grandparents alive. My grandparents are not, and even like cousins and things like that. I was never around really young kids either. Like we're all within a few years of each other, so I was never around very old people who were still halfway independent, and I was never around really young people either. So like my career has never really involved different age groups other than my own, really, until we started Right at Home. And so I'm always really curious how people kind of got to their, what their map has looked like up to this point. So that's
right.
Great. So tell me a little bit more about like the perfect maybe family that you work with, and now I want to go into like some other questions just about maybe situations is the best word, but like maybe those outlier situations that you see where it's like, okay, I can absolutely help this family no matter what, because the impact you can have is going to be so big. So what is just like an ideal client to start?
Right. Well, like you said, scenarios are the easiest way to explain it. So an ideal client, one family called me because their mom lived near me, and both sons live out of town and have high power jobs, honestly. And their mom was slurring her words, and they were worried about her. And so they said, Jeanie, can you go do an assessment? So with every client, I do a holistic assessment. You guys do an assessment too. Right at Home does a great assessment. The only difference with mine is probably I'm looking into legal and financial too. I look into people's budgets, and if they haven't streamlined that, then I get them a financial planner, and I make sure their legal documents are in place. And there's probably a few other things to my assessment, but our assessments really overlap. But it's so huge. You go in, and so you got to find out the baseline. I always think it's funny, and this is just a tangent, when people think they can do an assessment over the phone, because it's never accurate, ever. I love it when an adult child's like, my mom's bedbound, and she's walking around with a cane. Right.
Or the opposite.
Like, or the opposite.
My mom's walking around okay, and you go and she's not getting out of bed.
Yeah, two-person transfer. Right. So this family, I went in and looked at the medications and the caregivers, and I called you right away, but the family wouldn't switch. But anyway, and
okay.
It was funny, and I just thought, I'm going to start off with, let's look at your meds. So she was not taking her meds at the right time, I don't believe. She had pill bottles everywhere. I'm not sure that she was hydrated. So basically, I had caregivers that were already there start keeping a journal of exactly how much she was eating, the percentage, when she was drinking, and then I filled out a pill minder, that's why I call them, and made sure her pills were lined up, and within 48 hours she wasn't slurring.
Wow.
So, because they said, does she have dementia? And I did the dementia test, and since I'm a social worker, I don't normally go, so count, backwards by sevens, because that's mortifying and embarrassing. I just kind of...
I'm not sure that I could...
Oh, I can't do it. There's no way. I know. Or the date, right? Like, no one knows the date because we all have smartwatches. But I just kind of do it because I know how to do it. And I just thought, she does not have severe dementia. That was just my gut feeling. But so I just kind of got her going. I didn't like one of the caregivers, so I said, and I think we'll be setting up a camera system inside and out, just make sure everybody feels transparent about how this care is going, and got their attention. And then I set her up with a gerontologist to review all of her meds and get going. So
that's like that was like a huge impact. Obviously, super quick results just from cleaning up the process of medicating, really. I mean, eating the right food at the right time, taking meds with or without food, and making sure there's enough water and hydration. Right. I think, and typically we see similar kinds of things where the biggest impact stuff generally has to do with just scheduling and keeping people consistent, and we're going to wake up. We're going to get up and out of bed. Right. We're going to go on a walk around the house or around the neighborhood or whatever we can do, just to like have routine. And I think that word is probably going to continue to be pretty much in the top 10% of importance when we go into a home, and obviously when you do as well. It's just getting that routine set that makes sense. I think you mentioned assessments, and I know for us, like whenever we do an assessment, I have in the back of my mind where it's going to be 20 to 40% different in a week or two, because you can only find out so much in an hour or two of an assessment. You really have to have like eyes and hands and ears there for a while before you're like, oh, that's an interesting thing. There's no way that they would think about it, and it's pretty unlikely we would know to ask that question
in the first hour
the right way. So I always go in with that mentality of like, if we can get it close day one, that's the goal. And then knowing, perfection is the direction we're going to move, but very unlikely to start there.
Oh, right.
It's like, let's just get on the same in the same chapter, and then we'll eventually get on the right page.
I love that.
But I think, you mentioned cameras, and this is one of these questions I'm going to probably ask everybody, because I know it's one that we roll around in our heads a lot, is technology in the home. I'm pretty anti-technology in a lot of ways. You can't replace a person, is
right.
At least in healthcare, you can replace tasks, I think, with technology, but I think it'd be really tough to do like a full scope type replacement of a person. So do you see anything where, kind of the clients that you're working with now compared to earlier in your career, where clients are a little bit more open, a little bit more forgiving, and a little bit more maybe, I guess, open,
willing to engage
willing to have more technology in their house?
A little bit. So the nice thing is the technology is even moving away from the cameras and more into infrared. So I prefer, they are more willing to do, of course, the pendant. And to them, that's technology.
Yeah, that's been a while. Yeah.
Yep. And they're okay with their kids having some cameras in the house. Like, obviously, they don't like it in the bedroom or the bathroom, and I get that. So we kind of do the hallway for privacy. They're always fine with it outside, and they are great with their kids having it on their phone. But the people who are more independent prefer the infrared, and I have not installed that with somebody, but I love it. So all these algorithms and all the stuff that I don't understand, because I'm a social worker and not a computer person, but it's beautiful because data drives everything, right? So now, instead of having a camera, they've got sensors for falls, for velocity. They've got the infrared. So if you have someone who normally gets up twice to use the bathroom, it's got that data. And then 3 weeks later, if all of a sudden they're getting up every 45 minutes, it gives you that data.
Yeah.
And so we're not watching them with the camera saying, oh no, you've lost your privacy. We're just saying, we're looking at your rhythms and your routines, and when they change, the whole system tells us. And so they're good with that because that gives them more privacy.
Yeah, that's a good point. I haven't really looked too much into the infrared camera piece, but I know for me, I wear a Garmin watch, and it has like this great battery, so it also has sleep tracking, and I'm willing to wear it. And the next morning I can pull up the app, and it says like, okay, you got up 2 times last night.
Right.
And in my case, I have young kids, so you got up
times.
like 18 times. Yeah. And it's like, but it's got that accelerometer in it, so it knows like, are you rolling over in bed, or are you actually like walking around somewhere?
Yeah.
So I think there's some interesting things there. Right now, I feel like maybe one of the biggest hurdles with using existing stuff has to do with like, it's so overwhelming. So for me, if I was to check on my parents who live about 200 miles away, so it would be me logging into my stuff. It'd be me logging into my mom's stuff, my dad's stuff. There's just so many logins, and it just gets like, I mean, you could spend 2 hours a day just checking all of your accounts, let alone if something's actually there to look at.
Yeah.
It's just super overwhelming. So I hope somebody's out there trying to figure out how to curate all this stuff and to like, just let me know if something's wrong.
Right.
Like,
Exactly.
I can't just like go in and check to see if something's wrong all the time, because I think that's ridiculous. But
I know.
But I think just let me know if something's wrong, and then I can dig deeper from there. But,
Right.
One thing that we've been doing and toying around with and seeing if we can actually scale it has to do with some Amazon products, like Alexa Cares, I believe is the name. It's gone through a few name iterations over the last few years since we started digging into it, but it's the video Alexas.
The drop-in.
And you can drop in without having the other person have to answer the call, which I think is super key.
Oh, yeah.
And really something that we're utilizing for things like med reminders, where traditionally we have to charge a client an hour-long shift just to have someone go in physically and say, hey, Mrs. Smith, we're here to make sure you take your meds. And really Mrs. Smith is okay with that. But after the 5 minutes that takes, she's like, okay, please, I'm going to move on with my day. I think you should too, you know, kind of stuff.
Right.
And so this is you know, maybe an initial way for us to provide that same service that we've done, you know, all over town for dozens of people. We can do in 30 to 45 minutes for dozens of people from our office, and people are still getting that, you know, that peace of mind of knowing like, okay, there's a schedule to the meds. We, you know, they're showing what they're taking, or they're opening the correct day. And that's a comfort for, you know, the adult children who, you know, who may or may not have those moments at 9 a.m. to do that, because they're obviously raising their own kids and dropping off school and getting to work and all the other reasons that there needs to be so many hands to really help people age safely, is maybe even a better word than independently.
Yeah, right.
So yeah, so we've been playing around a lot with that. I don't know that it's a super scalable solution, because it's like, okay, let's put one of these Alexas in everybody's house, and, you know, are we, you know, what does that look like, you know, when there's, you know, 25, 35 clients, and we're really only dropping in for 2 minutes a day. It's a lot of stuff to be able to justify that, but I think that there's definitely something there. And
your scheduler could do it. Your scheduler is amazing.
Yeah, she's awesome, isn't she?
If anybody can do it, she can do it.
Yeah, quick shout out to Kat. She's awesome. And I think, you know, we've toyed around with some other stuff technology wise over the years to see what would make sense. There's the fall detection stuff. There's cameras. There's the sensors. Like there was one that would sense when the refrigerator opens.
Oh, nice.
So it was like, the assumption is if it's opening, they're getting something from it.
Right.
You know. Right. And there was a faucet one that you could, like, are they at least turning the water on? And I think that stuff is interesting. It also feels super intrusive, and I totally get that. I personally, I know that's the biggest hurdle, and so I think it's just finding that middle ground of what's helpful for whoever's you know, involved with the care, but also what are the clients or the seniors willing to be okay with, because it's just a lot.
Well, and so much of it, that works so much better with people with cognitive impairment, right? Like if they have even mild dementia, cognitive impairment, some type of long-term Alzheimer's, they're the ones that you can do more of that watchfulness with, because they're just not aware of it. And yet they're aware enough to know, I don't want to go anywhere except for home. So it's this perfect place to use technology. I love the Alexa drop-in. Love it. I started using it during COVID.
Oh, cool.
Because I would have clients whose loved one would be in a nursing home and no one could go in. And they would be declining, and there was one situation where the wife was outside trying to get him to bring her husband to the window, and the husband couldn't figure out how to use the phone. He was in his 90s and declining, so we did drop in, and she could just at any point drop in and talk to him. And
I love that.
We get through HIPAA pretty easily, right? If it's only facing your client, then you're okay.
Right, right.
So it really, they had this whole HIPAA issue, and I said, yeah, right, it's okay. Like, we can, this is the 21st century. We really can figure out, I mean, HIPAA is an old law. It has to morph with the times. I mean, it really has to catch up with how we go. But I do think those things work much better with mild cognitive impairment.
That's an interesting point. I hadn't really thought of it quite that way. But yeah, you're right. I think beyond the technology part, I think what you're doing is as playing kind of the aggregator and the manager, or the care manager. But like, I mean, in the beginning when we first started talking, you mentioned like doctor's visits, and, you know, is it grocery shopping, and not that, or it's just making sure that the grocery shopping is happening, right? I mean, it's like, I can't imagine. I mean, even if I lived across the street from my parents, that's very overwhelming for me to think about. So, have you seen, like, generally speaking, are your clients, are the adult children, do they live predominantly out of town, or a pretty decent mix, or how have you seen that play out over the last couple of years?
It is a mix. I do think more sons call, because more sons are not dying to know how often their mom needs Depends and how often they don't really want to know the routine. They just are busy running a business or whatever. And the daughters have a little, I think they're embarrassed if they aren't on top of it all. And so they don't ask for quite as much help. But I do partner, I think, in and outside of town. I mean, I have several clients in town that live in skilled facilities. Yeah. And all facilities are understaffed now in the whole nation, I would say. I don't know one care manager, it's a national association that doesn't say that. And we're in touch daily as an organization. And so all my clients have caregivers in facilities. I mean, I don't think I have one client that doesn't have a caregiver in a facility, because even if it's 2 or 3 hours, I have to make sure that the food that's put in front of them, that the silverware has been opened, and that the drink has the straw in it, and that just doesn't happen. I mean, and it's not, I'm not dissing the CNAs. I know I'm from the 80s dissing, but like, I just think they have so much going on. They're just excited that they got the food out to everybody and it's still hot. So if state shows up and they measure the temperature of the eggs, they're not in trouble. But it sits in front of our clients and it doesn't get eaten, or they don't get out of bed because they're so understaffed. So all of my clients in every facility, when they first go to the facility, have 72 hours of private caregivers. Yeah. Period, end of story, because they transition and the family would never know that. The family knows the first 72 hours they can fall and go right back to the hospital and go right back to rehab. But the families in town need my help to figure that out as much as the families out of town. There's a family in town right now that I'm helping, and the dad's in rehab, and I have caregivers there, and he needed a swallow test. So they go over to get the swallow test, and it should be just fine, right? The facility gets them there, the caregiver's there, it should be totally fine. But when we get there, the order's not there. Well, no one in the room knows how to get an order. But I do, and the DON does, and I've already built the relationship at the facility, so she and I are texting saying, let's get this order so that this 90-something-year-old man doesn't have to go back to the facility, reschedule this. Yeah. So even people in town can use the expertise of a care manager, just because those little things like getting an order in 10 seconds matters for quality of life.
Yeah. Well, and I have, like I mentioned earlier, I didn't come from healthcare. I've obviously learned a ton in the last 6.5 years, and really, at the end of the day, I feel like I know quite a bit, and I can't even imagine going in and figuring that out by myself. Right. Like I even as much as I know, which is way above the average person at this point, I still don't feel comfortable that I would be able to think to ask all the right questions, or I think I'd accept answers pretty naively because someone's giving me an answer confidently. And and that is probably one of the more scary things. And it's not even against that person giving the answer, it's just against but do they know that, mom or dad or grandma and grandpa are on this other med that this other doctor did? And I think centralizing a lot of those records is going to be a continually, it's going to be required. It is required. It's just there's not enough services that are figuring that out quite yet at great scale, which is going to be interesting over the next couple of years. I think that's going to be a big driver in quality of care and quality of outcomes. Oh, man. And tracking that data. I know Medicare tracked readmission rates for a long time, and they still do, but there's just this growing dependence on the data, because there's just so many people and so many specialties. So like I can't just go to a doctor anymore. I have to go to like 6 doctors for 3 different things, and there's it's just going to be a huge driver in everything that people are doing. I mean, and I would think at some point there's going to be enough data on people, not in a creepy way, but just a helpful way, that'll say, hey, because of this, and this that came from 3 different places, you really need to like consider this 4th thing to replace these 3.
Right.
And I think they'll be able to kind of tease out some, the problem of over medicating, and which is a massive problem. Like,
I hope.
And we've gone in to homes and it's like, well, we take these 12 pills in the morning. It's like,
no,
like that's I feel like too many, no matter what you've got. But obviously I'm not a doctor, so but I think that's going to be probably one of the bigger impact things of that, the record sharing, the transparency of medical records is going to be a big thing over the next couple of years. That will drive some new developments and hopefully better outcomes.
Hopefully we're filling in some of those gaps. So care managers have our own computer programs, but most of us have a HIPAA compliant patient portal.
Yeah.
And so we have all the doctors, all the meds, and all the doctors have our medical release form, so we can talk to all of our clients' doctors. Yeah. But the doctors can also get into our portal.
Oh, that's
so
nice.
At any point, the cardiologist can say, I'm changing this med, and Jeanie, do you have the list of all the other meds? Or if they want to, they can just log into the portal. They have medical access. They can't see, that I brought her to Aunt Susie's yesterday. But so we're hoping that we can centralize some of that. But, I'm with you. It's a long ways away. But, you said something that made me think about the advocacy there. I have to say, medication mismanagement happens 9 out of 10 times. I would say anytime you're going to a new doctor, going to a new facility, leaving the hospital to rehab to assisted living to home, every single time, 9 out of 10 times it's messed up.
Yeah.
I don't know how.
It's crazy.
None of the systems talk to each other.
Yep.
It's unbelievable. But one of the things when you were talking about, I'm not sure I'd know what to say in that moment. I think care managers love maybe we're a little bit addicted to drama because we love to go in and just be in the moment and solve. Maybe it's like an ER nurse, right? Like just show up.
Yeah.
But there was a family who had a really knowledgeable daughter out of state, and the other family was here. Her dad had some medical issues and was declining, and they were saying he was pushing back behaviorally. And she just didn't believe him. So she called me and said, Jeanie, can you show up? And it's that high heel thing. So I showed up and said, I need the hospitalist, had a case management, head nurse to meet me in about 20 minutes because things are happening. And they did. They didn't know who I was, which is great. So all the leverage. But I showed up and just asked the questions. I'm not a doctor. I'm not a nurse, but I know how to ask the questions. And so I asked questions, and at the end of it, I said, so I'm just kind of wondering, and I had the daughter on the phone. She was asking questions, and I'm just kind of wondering why I didn't have this surgery about 12 hours ago. And no one said anything. And I said, well, I was just sort of wondering if maybe he could have it in the next hour. And they said, yes, because we don't want, risk management to get involved in this. We will be happy to get on top of this. But it's just knowing those questions to ask where care managers are in these crazy situations, and we learn every time. I mean, we're always learning, but we learn and we're able to apply it to our clients. I learned recently with a client who was very high need. He was on seizure medicine and went to the ER, and I just sort of knew the ER was not going to know he was on seizure medicine. It was like life or death. So I called the nurse and I said, you're giving him his meds, right? And she said, no, when you're in the ER, you don't get your medicines and you don't get fed. I said, well, you're going to have to give him his meds. Like, this will probably be a big lawsuit if in about the next 5 minutes you don't get this guy's seizure meds, because this is life or death. And she said, okay. So she got him right away. But now when my clients are in the ER, I'm bringing Chick-fil-A. I have their meds. I have them medded up before I go, get their Percocet in them if they're on that before we go, because I know they're not going to get meds for 8 hours because they're going to be sitting there in the waiting room. But did you know that you didn't get food or meds when you were in the ER?
The only reason I know this is because the number of inquiry calls that we would get, especially when we first opened, where I would go to the emergency room at like 1 a.m. to sign up a client. And I after learning that, I would do the same thing. If I ever went, I would just bring food of some type with me, and obviously clear it with like, hey, is this okay that they're eating something?
Yeah,
you know,
are they
I don't know
diabetic?
I don't always know what the situation is, right? So yeah, like diabetes or something. But yeah, that's the only reason I know that is because of the number of times I would sign people up for service in the middle of the night at the ER. But otherwise, I would have no idea.
Right.
And I've been to the ER for myself for silly youthful accidents or whatever. But you don't think about it when you're, you get a laceration or a broken arm. You're not really thinking about it.
Right.
But when you're, an older person who's on several meds and some with food, some with whatever, I would never have known had it not happened several times with me being like, wait a minute.
Right.
This doesn't make sense.
And the ER is so different now than it used to be. I was on a panel with somebody else the other day, and we were talking about the future of healthcare and how it's going to change with so many more older adults, but it has already changed. I mean, you used to be in the ER for less than 8 hours with a broken arm in and out, but now, 8-hour waiting for even to be seen as minimum. I don't think I've had one client in the ER less than 12 hours for a cold, for any, I wouldn't take a client for a cold, but even for something small. Sure. Healthcare is so different than it used to be.
Well, and that actually makes me think about a couple other trends that we see that we're starting to be a part of. One of which is hospitalization at home, and that is a big. It's coming. Oh yeah. And it's very interesting to talk to with people, because the only people that are kind of willing to talk about it are pretty forward thinking and it's. There's a doctor that we work with here in Chattanooga that we're probably going to have on here to talk a lot about it, because he's on the forefront of a lot of that. He's kind of concierge medicine and just a totally different approach to that level of care, which is really, really interesting and fun to think about, because it's like, man, this is going to provide those patients with a completely different experience of this particular, moment in time. That they would be at the hospital. And it's not appropriate for everything that you'd go to the hospital for. Obviously, there's a few obvious things, but there's that's a thing. Another one would be micro hospitals. Have you heard about this?
No.
So they're essentially the same kind of idea, right? Sort of private pay hospitalization, but it's going to be more kind of boutique style, where it's like maybe 4 to 8 beds total. Wow. And servicing not just like an affluent population, but thinking about that model in outlying areas or rural areas, that a super low cost way to have a hospital available, as opposed to, okay, what's the threshold of, even going out into the middle of nowhere in those small hospitals, they're still big, they're still require a baseline of staff, whether or not someone's there or not, and so anyway, this micro hospital thing, I think, is going to be another one.
I love these trends.
It's pretty interesting.
Like, have y'all started using the chair that you put together underneath somebody to help lift them up so they're not a 2-person transfer?
No.
It's so cool.
No.
So I love it. So say you have a caregiver helping someone, but they're kind of heavy. Even with y'all's caregivers, if they fall, it might be a 2-person to get them up.
Sure.
Now you don't have to do that. There's these things where you put a chair together underneath them. It kind of ends up looking like a folding chair. So you only have to be able to roll someone halfway in the other way. It comes together, and then the chair comes up and it lifts them up, and then they stand up.
Oh, cool.
I just love all this future stuff. And then a friend of mine just invented this blue pouch for getting showers in, so that the people with cognitive impairment, when their skin hurts and they're out of sorts or they're modest, I mean, doesn't have to be cognitive impairment. Some of these older men are like, you're not looking at me or touching me or whatever.
Yeah.
But it's this big blue thing. It kind of looks like a koozie, to tell you the truth. It's kind of funny.
Yeah.
But you can do a shower within that, inside and out that, and so it doesn't hurt their skin, and it's getting them clean and providing privacy. I have a friend who's investing in medical technology because it is just on the move, and I love it. I want it to help our clients.
Yeah, it's a pretty fascinating time to be in healthcare, because it's riddled with issues, which means it's going to be riddled with solutions, because people are smart, right?
Mm-hmm.
And you know, I think everything kind of reaches a tipping point, and healthcare has done that, you know, for all intents and purposes, and there's just going to be all kinds of solutions, and I don't know, it's pretty exciting. So I want to come back to a couple things. You mentioned staffing in facilities being just down everywhere. I mean, and it's, you know, I think that's right at home's, you know, I wouldn't say it's changed. I mean, it changes every other month, right? Where what's the biggest thing holding us back from growing or something. But honestly, I think, you know, the last 18 months, and I guess if you're listening to this or watching this later, we're January 11th, 2023. And the last 18 months has been really tough. With staffing and recruiting, and retention being maybe even harder than recruiting, just keeping people, right? Because it's, you know, it's just hard to figure out, and it's not that people are unwilling to figure it out. It's just, it's a complete difference than it was 18 to 24 months ago. So it's it's hard to adapt like that quickly, or to find solutions that quickly. And implement those changes super quickly. And so it's everybody trying all kinds of things, and people are starting to figure it out.
They are.
So I think it is changing. I know for us, recruiting and retention has gotten quite a bit stronger over the last 90 to 180 days or so than it was, you know, a year and a half ago.
And your changes are good for me. So,
right.
Because some of your new people, some of your new recruits, and the new people that you're training, every single person has a different level of, experience, right? So you may have someone who's in their 60s, a retired nurse, is all over the meds, gets that, can go to the doctor with your clients. Or you may have someone newly out of nursing school and just is getting, or, you know, CNA, getting their nursing degree. So we come alongside and partner with your people because they're an amazing caregiver. They're right there making sure they're not falling. All the meals are done. But if they look at meds, it's like dyslexia. They're like, I can't do this. So it's so like your change in industry is good for my change in industry, because it's a good partnership.
Yeah, absolutely. Without a doubt. And I think a couple things that we're looking at regarding, you know, how do we do more with less? Because that's where everyone's at right now, you know. And so I don't jump on the technology things super quick, or you know, definitely not publicly jump on those solutions and assume they're right. But one thing that we do see changing and happening is looking at staffing, like actually scheduling and staffing caregivers or personal care aides or CNAs by zip code more. And so, you know, how can we get this caregiver who's helping, you know, Mrs. Smith for 8 hours a day? Is Mrs. Smith going to be okay with being seen 30 minutes of every hour of that 8 hours? And then, you know, John down the road getting care 30 minutes of each of those 8 hours. And so really looking at trying to reduce the cost for the clients, pay the caregiver more, and both people are getting 90% of what they would have gotten had someone been there all 60 minutes of every hour for 8 hours.
That's brilliant.
And so
Oh my
I think
gosh.
that's going to be a big push this year for us to really see how able or willing clients are for that type of service. And there's certain people that wouldn't fit that box, right? If they're cognitively impaired to the point that it's a safety supervision is a big part of that care plan, that's not going to make sense,
Right.
For that person. But there's a lot where it's like, okay, so 30 minutes of every hour for 8 hours, they really don't need 4 hours of care because there's something that happens 8 hours later that they need help with, right? Maybe it's a
Right.
meal or meds again. And so it's really an interesting way to think about it. And I think pushing the scheduling and staffing piece to be focused on zip codes and even neighborhoods or streets is going to be the direction that we're going to try to go and in moving forward with the way we do things. So I think that's a big one. And then I think my one of my closing kind of wrap up questions, so and I'm not quite to the wrap up yet, obviously, but I'm curious how people learn. So are there go-to resources that you have that you're like, this is a place that maybe it's a blog on the internet or an association group or what, those types of things that you are kind of flexing your education muscle still, because even with all your background, everything changes so quick.
Oh yeah, right. And I do 30 hours of continuing education every 2 years, just like licensed clinical social workers do, and my whole staff does. Because you're right. I mean, as soon as you think you know it all, you don't, and it's going to hurt your client. I really like Teepa Snow. That's a really weird name of a lady, Teepa Snow. She's an occupational therapist who's a dementia trainer and specialist. And so I would say I use that with every single one of my clients who has any issues with that. I've volunteered for the Alzheimer's Association for the past 10 years. I've led a support group, and so I'm always calling on the Alzheimer's Association resources. But recently, and I think I've done a lot of research online, and I really don't want to send my clients to someone who's going to sell them something.
Sure.
I'm trying to keep them protected. It's not that they don't necessarily need to buy that stuff. I mean, if it's a pill minder, great. I mean, it's not a bad product, but I just don't want them to get distracted by all the selling, and I don't really want their email going to these places that are going to call them over and over. So I've been sending them to care.com a lot because I can link them with articles. That they have articles, blog posts, and it's been great. Like I have some for bathing or some for how to have the conversation of if you need care in your home, how do you talk about the elephant in the room. So I do a lot of articles, but a lot of my education is, to tell you the truth, people are calling me for that education.
Yeah.
So they'll call me. It's so funny. Like the most brilliant people call me, and I'm like, you're way off the chart smarter than me. Like my IQ is probably half of yours. Surely it's half. I mean, anyway, some amazing scientists that I've worked with, but their parents are resisting care in the home, and they just say, can you tell me what to say? And I'll say, well, why not I just come? And when I come and do the assessment and do coaching, then I'm doing on-the-spot education, and then I do ongoing education. So a lot of that is I'm using the resources of trusted partners that aren't selling them, to an email list, but I'm also come in and do the actual coaching with them, because I want them to, you can tell someone, to redirect someone who doesn't want to shower and come back in 10 minutes. And that's like the typical go-to answer for someone who doesn't want to have a shower is combative, but they kind of want to know what to say to their mom or their dad. Like, here's my dad's personality. My dad could care less about privacy, but cares about the temperature of the, everybody's family is so different. Yeah. So a lot of my education is just in the moment with that person, just saying, okay, here's the typical answer, but how does that fit with you? So some of it's me educating, I guess.
Sure. Yeah. I would think
but
absolutely, like you're playing that role of educator and navigator and
but I'm staying educated. I'm listening to doctors and specialists, and I love occupational therapists. They're so hands-on, and any technology thing. So Yeah, I definitely am. I'm sure we all need to learn more, about all these details or more medical, but yeah, we're trying to stay ahead.
Yeah, I love that. So, if people are interested in what you do and what your staff does, what's the best way for them to get in touch with you?
Right. They can go to our website and call. They can go anywhere online. Hopefully, I'm all over social media, so
Sure.
they can contact me that way. Anyone they're working with, hopefully, the word's out more and more. Their caregiver, their doctor, their attorney, their CPA, any of that, you can just email us, call us. We're pretty
Perfect.
easy. Text us.
Perfect. And what's the website?
agingcaremanagement.com.
Okay, perfect. And we'll put links and stuff in all the places and and phone number and all that contact info for sure.
Sounds good.
Well, Jeanie, thank you so much for
thank
doing this.
you.
This was great. Yeah.
Good.
Worked out perfect.
Good. I
All right.
appreciate it.
Yeah.
Thanks.